let us know when you're ready for breakout groups and we can do that.
Okay, sounds good. All right. So hi everybody, my name is Yousufzai. I'm a second year resident in the primary care program, and my talk is on refugee and immigrant health. It's kind of like a broad stroke, but I'll be focusing on some specific topics. So first, acknowledgements. My personal acknowledgement is that I have a personal history as a refugee from Afghanistan, and I've worked with refugees in some capacity since grade school. And also I want to give a big shout out to ethnomed.org. I've adapted a lot of the content from there, as well as some other resources online. Ethnomed.org was developed at Harborview by staff, patients, providers, in conjunction with Upper Campus at UW. And includes their Interpretive Services Department, IMC, GIM's Refugee and Immigrant Health Promotion Program, as well as others. And I also just want to give a shout out to Dr. Carrie Jackson and Nicole Arenholtz for some guidance and inspiration. They were my attendings on Words last month, and it was really fortuitous. So in the midst of all that craziness, they provided some inspiration for this talk. All right, so our learning objectives. So first, we're going to define some terms. We're going to learn about systematically screening newly arrived and connected. This can be both refugees and immigrants. Practice cultural competency and humility. Utilize some online resources. Assess and interview survivors of torture. Be aware of coverage of undocumented people. And familiarize ourselves with our caseworker cultural mediators. Okay, so first some definitions. So this is a definition of refugee by UNHCR, which is the United Nations High Commission for Refugees. I'm going to read this one out loud because it's pretty encompassing. So a refugee is a person who, owing to a well-founded fear of being persecuted for reasons of race, religion, nationality, membership of a particular social group, or political opinion, is outside the country of their nationality and is unable to, or owing to such fear, is unwilling to avail themselves of the protection of that country. And the context I want to give is that a refugee is somebody that has been given that designation, and that's one of the main differences between a refugee and an asylum seeker. I'm not going to read this definition, but it's an asylum seeker is somebody that may have all of the same fears, but they have not been designated by the bodies and powers that be as refugees yet, and thus given that protected status. One thing to note is that through many international laws, and including laws in the US that have been adapted from the Geneva Convention, everyone should be allowed to enter another country, including the US, and seek asylum. Whether they get it or not is less standardized and more subjective. And then a migrant is something that we also hear quite a bit and has more of a loose definition. It can be anybody that goes to another country for work or study or join family, but it could also be people that have the same fears that asylum seekers and refugees do, and we often hear this term being used when we hear about migrants at the border or migrants in Europe, but we don't necessarily call them asylum seekers. And the reason we define terms is, as we all know, language matters. So I'm going to give an example of why this matters. So I want us to all imagine a guy maybe from the US who moves to Portugal. He finds, to get a work visa because the cost of living was low, and heard there's a lot of job openings, and he wanted to join a community of others like him. May or may not look like the stock photo that I found of somebody in Portugal. So I'm just curious from the audience, what would be a term that we would use for this person? Feel free to just unmute or type in the chat, but I can't see it.
Migrant.
Good, I like it. Shri, what is another word?
I'm seeing expat pop up a lot in the chat.
Expat, yeah, exactly. I feel like that's what I most often hear, especially from their America or Europe or generally the global north. But you're right, Shri. they're migrant, but we don't seem to call them migrants, or we wouldn't call ourselves a migrant necessarily, but maybe we should. Okay, let's get back to being a little bit more serious. So refugees by the numbers. So this graph, I'm going to kind of distill some of this down. This is from UNHCR in 2019. As you can see, for quite a long time, the number of refugees globally, or displaced people, I should say, not refugees, because that's not their true designation, has bounced around between 30 and 50 million, which is still quite a lot. But you can see here, sometime around 2011, as a lot of wars, especially in the Middle East, conflicts in sub-Saharan Africa, and a lot of people fleeing violence in Central America, this number is nearly doubled. And you can see the number of refugees is significantly smaller than that, at 26 million. And what's even more striking is that only 107,800 in 2019 were actually resettled. So of that 26 million that were given the designation of refugees, that means 0.4% resettled to a third country. So while this number is growing, so I remember I did a similar talk in medical school, and it was about 1%. So even though the number has doubled, the number of countries, or the number that the countries have accepted, has not changed. Even though we hear of all of these, quote, again, migrants fleeing to the borders in Europe and the US. This is a little bit of a complicated map, but it shows you a lot of the various ways that people seeking asylum, the routes that they flee. And I want you to first take a look over to the right. You can see in Africa, sub-Saharan Africa, the Middle East, and even in Eastern Europe, some of the paths, and it's quite complicated paths that they take. And then on the left is just one of many paths that people make overland journey from South and Central America. And the thing that many people may not know is that a lot of people that are seeking asylum will actually flee to Brazil. For some reason, it seems to be easier to go to Brazil and often Sao Paulo, and then they'll make the overland journey, often ending up in the United States. And while they're a small portion of the people that we see at our southern border, there is a significant number that will be from other parts of the world than just the Americas. All right, so let's talk about refugee health screening. So typically, at least in King County, this occurs within 3 months of refugees first arriving and being resettled in the area. Although this is not fully standardized and tends to differ even by county. So in King County, this occurs at the Public Health Seattle and King County Refugee Screening Clinic. It's in downtown Seattle. It serves the role of triaging acute health needs, documenting immunizations. They'll do various screenings, and then with the goal of then getting them connected to a primary care office, but that doesn't always happen. And they need to stay in the county for there to be any proper follow-up of this after they arrive. And they need to stay to get some of the benefits that they would receive if they were to leave because they wanted to go and meet up with family that lives in another county. They may be lost to follow-up. So I'm going to give an example here of a potential refugee in your clinic. So this is a 32-year-old man with an unknown past medical histories presenting to your clinic as a recently arrived refugee from Afghanistan looking to establish care. So what kind of questions would you ask? And again, I'm just going to let people either type in the chat or just unmute yourselves. No wrong answers. I want some participation.
Somebody's saying, have they received prior medical care?
Okay, good. Thinking back on our slides, what else do you want to know?
Asking, do they have a safe place to stay, past medical history, what route they took, history of trauma, physical or psychological. Those are all kind of coming up.
Great, awesome, I love it. There we go. Yeah, so their timeline is very important. Again, part of the reason is that a lot of the medical benefits that they receive will be within, they'll get medical benefits that are given to them outside of like Medicaid, Medicare for 8 months. But yes, exactly. Where did they come from? So most refugees will be processed in a camp or a second country before being granted asylum to be settled to a third country, such as the US. And as we think back on the map, they can take a very long and often traumatic journey. Even before, in addition to the trauma that they faced when they were fleeing, they face further trauma just through the journey that they take, often at the whims of traffickers and local police forces and military forces. And then what is their housing, social support, as we all mentioned, employment, education? Did they attend the post-arrival assessment and screening? Do they know their immunization status and past medical history, as you mentioned? So in this case, this patient moved here 3 years ago in 2017, or I guess 4 years ago. Was previously working as an engineer and new graduate, has been studying ESL and working at a grocery store, fled Afghanistan through Russia and then to Serbia, lived in a camp for 4 years before gaining refugee status and being resettled in the US. Believes he did get childhood vaccines but can't recall which, and one of which has left a permanent scar on his right shoulder. And believes he went to a doctor when he first moved here, but he can't recall what went on and doesn't have the records. So if for some of you that may know me, may recognize that this is actually adapted from my own life, other than the fact that I moved here in 1998. But since we don't focus on pediatrics, we're going to assume that this was made just, I guess, 4 years ago. So let's say you saw an adult version of me as a newly arrived. How can you figure out what do you need to do at that visit? So one amazing resource is CareRef from the Minnesota Department of Health that kind of summarizes all of that quite well. So I'm actually going to click on this and we'll do this together. All right. So right now we're residing in the state of Washington. The departure host country, that's where I came through. And Afghanistan, number one. It's one of the few places we're number one often. All right. Okay. Okay. So we're not going to go through and read all of this, but I just want to really show how amazing this website is. So it gives you this quick little thing on COVID-19, gives you a lot of best practices and just ways to think through this first visit. And then some of the general lab tests that you want to get and some guidance on it. And then really focus disease-specific tests and why and additional considerations that you need to take. And all of this doesn't need to happen in the first visit. Some of this is quite a lot. But there are some specific recommendations and things that you may not think about, such as parasitic infections, such as Giardia, syphilis, etc. But it also gives you a little bit of a guidance, some standardized way to think about mental health, substance use, sexual history, etc. So I highly recommend this. I can put this in the chat at the end of this this talk if people are interested in this. And you can use this with patients who are immigrants as well, not just refugees, because there's probably even less standardization in people that come here as immigrants. And even for all of you at like Belltown Clinic or that serve a lot of our South and East Asian patients who come here for the tech industry, who may also have spouses that come with them that might be less connected. This is also a good way to understand what kind of endemic diseases and other health considerations you need to make based on where they're coming from. So yeah, I'm not going to go through this, but this could be like a potential first visit if you're going to focus on just like the medical problems and the lab tests that you want to order and how to think about them. All right. So now we're going to break off for just 10 minutes. There's a case discussion. I think I sent it in an email, but I wonder if I can throw it into the chat now or if that's possible to throw into the chat. But we're going to break off, talk about 10 minutes, and this is to discuss a case of a follow-up visit with an Eritrean refugee that is new to the clinic. And I should have had the document ready. Emily, I'm not sure if you have it, but let me see. I'm going to try to throw it in now. Sorry for the delay. Okay, should be uploading. Oh, thank you for the website, Emily. Okay, so go ahead and.
Great, there it is. And then let's see if we can get us into breakout rooms. Javel, are you able to help?
Yep, are you ready, Haseeb?
Yes, go ahead. We'll see you in 10 minutes.
Thanks.
Perfect.
Thank you so much.
All right, let me pause this.
Again, welcome back, everyone. I'm going to put this again to the group for people to unmute or share or type in the chat if you feel more comfortable. What are some of the things that your groups discussed? And what were your reflections?
I think we talked a lot about like kind of letting, can you hear me? Yeah.
Yeah.
Letting the patient kind of lead at that first visit and really focusing on, okay, are there like some active infections that I need to chase? But otherwise just like letting them build rapport and comfort, kind of earning the next visit and closely following up with them. Because they may not be ready to like dive into all of their other concerns just yet with someone they just met.
Great.
In the chat, I'm saying agenda setting is really key.
Yeah. So what was the outcome here beyond the symptoms and the reactions to the antibiotics? Was this a positive outcome, a negative outcome? Neutral.
And it seems like it was a negative outcome for a lot of different reasons, although our team was discussing a lot of whether that should have even been the path that they went down, because we needed a little bit more testing to decide whether LTB was actually what was going on, given the BCG immunization status.
Mm-hmm. Yeah, good. So our group kind of discussed that as well. So the CDC guidelines, unless they've changed and I'm misremembering, are that you can treat LTBI with a PPD alone despite a BCG vaccine. The cross-reactivity does go down over time. But for that reason, many providers that see refugees and immigrants will get the IGRA and skip the PPD altogether. Okay. Anybody else? What would you focus on other than the LTBI?
Well, in our group with you, Haseeb, we talked about we had an opportunity to talk about his PTSD that was potentially sort of missed because we focused on the LTBI, which was not like an urgent infection to treat because he's otherwise young and healthy. And so we could have potentially had an opportunity to start addressing sort of his active PTSD symptoms if he was sort of feeling ready to start talking about those at that time.
Yeah, Anisha brought that up in our group because I think I jumped to the LTBI stuff too. And partly that's because like I haven't seen a lot of TB. I'm really excited about it and feel like this is something I can give someone a medicine for and fix. And just realizing my own bias towards things that I'm interested in or that seem easier to fix medically, when really what was probably most important to the patient's overall well-being is talking about his PTSD.
Great. Exactly. So I'm going to continue on from there in the interest of time. I appreciate those are all exactly the things I wanted to talk about. So we'll kind of touch base on this. This is a real case that I actually had in first year of medical school, and it has been burned into my mind, and I've actually talked about it quite a bit since. So yeah, the questions I thought of is like, what does the diagnosis of tuberculosis mean to this patient? You know, whenever you see a patient that's immigrant or refugee coming from an endemic region, you know, have they seen others suffer through tuberculosis? You know, when you're giving that diagnosis, how much weight is that going to hold? You know,
do they understand the definition of latent or active TB? I think that's something that obviously you need to talk to them in detail, but with somebody that may have seen other people die from TB and see how severe it is, it's probably more important to be careful with your language there. And should have focused on his symptomatic and very active PTSD instead. This is something that I took away from this, and could have the LTBI treatment waited for another visit. Again, young guy, doesn't have many other comorbidities or immunosuppression that makes you want to jump on treating this LTBI. You're not about to start him on rituximab, right? It's not an urgent matter. It's the way I would think about LTBI in most patients that you see. All right, so more than a checkbox. So thinking about humility and competency. So we talked a lot about like health screenings and having that objective data, but cultural competency in this specific instance is really important. So what do the diagnoses and treatments mean to the patient, open to their diversity of thought if they disagree with you, and curious to learn more about their backgrounds and beliefs. Reflect on your own biases and privileges, just as much as like your reflections on tuberculosis. And recognizing the power imbalances. So in this specific case, I don't know, but medicine is often used as violence against certain groups, and the U.S. very much including has used forced sterilization, experimentation, and exploitation currently and in the past. And then be an advocate, thinking about use of interpreters, bedside running, use of CCMs, which we'll touch on later on, but also systemic level changes, policy, advocacy, working with specific local organizations that impact your communities. So this is, I don't know if you all have ever heard of Kleinman's 8 questions. Arthur Kleinman, he's a psychiatrist and an anthropologist, I believe at Harvard, and he came up with these 8 questions that I really love, and I'm actually going to read them all out loud because some of them, they may seem a little bit obvious, but I don't actually think we do this a lot. So start off. So what do you think caused this problem? Why do you think this problem started, and when did it start? What do you think this problem does inside your body, and how does it work? How severe is this problem? Will it have a short or long course? What kind of treatment do you think you should receive? What are the most important results you hope to receive from this treatment? What are the chief problems this illness has caused? And what do you fear most about the illness and problem? You may not be able to dive into every single one of these questions and unpack them, but some of these questions in this case could have helped figure out the sensitivity around this diagnosis and potentially prevented this person from getting evicted and having their life completely turned upside down just by one visit at the doctor. All right, so now we're going to jump a little bit to talking about taking a history of torture. This is important, especially in cases of asylum. So documentation is actually quite crucial. It takes time and will take many visits. Don't expect to do this in one visit or your first visit. You'll often be working backwards. You'll be talking about the complications and symptoms associated with the trauma, some obvious, some not. Prepare the patient that you'll discuss this. Carve out time with very specific questions. And I understand that we fear triggering past trauma, but also many patients are grateful, and it also just allows you to direct treatment and also customize your treatment based on their traumas. So we're going to watch this video here. This is actually at Harborview International Medicine Clinic through Ethnomed. I want to warn people that it has depictions of violence and torture and imprisonment. So if this can be potentially triggering for you, the video is 6 minutes long. You can feel free to tune out. So I'll hit play and let me know if you can't hear it. All right.
Hasib, if you're not able to share sound, if there's sound that's going on now, under the share screen option, there's a button to click that says share sound.
Share screen. Oh, whoops. Oh, okay. I'm not seeing it. I wonder if I stop share and reshare. Yes, share sound. That's right. I forgot to do it again. Okay. Thank you.
Arrested you, and
All right.
I want to take you back to when you were first arrested in Iraq under Saddam Hussein. Can you tell me again, why was it that they arrested you, and what day did it happen, and under what conditions did it happen?
راحت فترة أنا رجال أشتغل كنت فيتر مع سيارات كبار زين لوريات أشتغل فيتر. اجونا على جيش شعبي لازم قالوا تلبس حتى خاف أمريكا تضرب العراق أو هاي بال95 زين. أنت لازم شلون تقولين غصبا على العراقي لازم يروح جيش شعبي. أنا سويت تهجمت وين؟ بعدين من يجون على جيش شعبي لازم نلبس بالعسكرية جيش شعبي. قلت هم رجعت وهاي بقيت أغلط على صدام، سبيت القيادة القطرية زين. الكفوني فرقة البياع أخذوني للفرقة 7 أشهر يعذبون بي. أول يوم كذوني زين قتلوني تعرفين بواري وبتوات وكيبلات زين. شلون ننتسب صدام، شلون ننتسب بالقيادة. أخذوني تقريبا شهر كامل أهلي ما يدرون بي، الشهر الثاني هم أهلي ما يدرون.
Let me stop you there and ask you, how is it that they arrested you? Did they find you at work? Did they find you at home? Who came and how did they get you?
لا يم البيت، يم بيت أهلي، يم بيت أهلي.
Did your parents see you arrested?
لا بس سيارات بيض أولدز وسوبر 82 شالني. سيارات 2، واحدة أولدز زين، واحدة سوبر 82 شالتني من شدوا عيوني وهناك استلموني كتل زين. التعذيب زين بأنواعه التعذيب.
What did they do specifically? Did they hit you? Did they burn you? Did they cut you? What did they do?
يطبون علي 3 زين. يستلمون أول مرة بالكيبلات، يدقون علي شلون نسب صدام، شلون نسب القيادة، أبونا صدام، أخونا صدام، هو كل شيء صدام زين. أنا أقول بقوا يضربون على راسي، بقى الدم يجري من راسي، بقوا آخر شيء جابوا بلايس وعوسنا شلون تحكي على صدام وتغلط على القيادة القطرية وتسب صدام. إلا نشلع هاي شل عوسنوني هاد تخم.
Did they pull all of your teeth at the same time, or did they pull them on different days?
أيام مختلفة. يا اللي يجي طب عليه مثل طبوا عليه 4 زين. أنا عيوني مشدودة وديري ورا ويطب واحد بدي بلايس زين. يقضون زين 4 يشلعون واحد يوم شلعوا 2 يوم واحد هيجي زين.
So they pulled them on at different times, is that right?
اي صحيح.
So you never knew when they were going to show up and when they were going to do something with your mouth?
ما أعرف هي الباب بس أسمع حس الباب انفتحت علي زين. أحس طبوا يقتلوني زين.
Now is this still at the party headquarters or is this at Abu Ghraib?
صعدوني بالمحكمة الثورة يصيحوا لها محكمة الثورة عندنا. أخذوني حكمونا أول مرة إعدام، حكمتك المحكمة إعدام وخذوا بيت أهلي من عندنا وعندي باسمي ياخذوا عندي مقتل. بعدين حكمنا إعدام. بعدين كسر القرار مجلس قيادة الثورة قال لك إنه والدك كان أسير وأخوك شهيد زين نحكمك 15 سنة. جابوني قبل الزنزانة.
Take your time.
جابوني لبغريب دبوني بزنزانة طولها 2 متر. خلونا تقريبا سنة كاملة فوق السنة بهاي الزنزانة يسموها الخاصة هي هاي.
Did they let you out to eat, to exercise, or do they keep you in there solid to that period of time?
هاي يخلوه علي زين. أبقى بالزنزانة أسبوع ويطلعون يخلوني أنظفها وأرجع بيها. ومن نطلع من الزنزانة ذول الأمن الضباط زين يقول هذا السبب صدام تهجم على الحزب وتهجم على القيادة ضربوني بالبواري بالتواتي بالبواري آخر شيء بال2000 خلص ال7 سنوات ونص زين طلعوني ورا 4 سنوات من الزنزانة دبوني ويا هذول التجاوز حدود وجايين هذول يروحون الإمام الحسين يمشون زين قالوا تبقى هنا.
So I want to recognize, that is difficult to watch, and that we have the privilege that this patient and other patients and other survivors of torture on ethnomed have allowed these recordings to take place for education purposes. And there's a lot of more context provided in longer videos, and there's examples of people from different regions and different countries facing different types of persecution. And I think this is important. I'm not sure why that green is not going away, but going back to thinking about being very specific with our questioning is, it makes our treatments going forward matter when we have that context of the torture and the trauma. So, this patient, if you were to send him to a dentist or for a dental care, or, it's important to recognize their triggers and things that may exacerbate their PTSD and history of trauma, or just knowing that they were confined in such a small cell. All of these things matter and will affect their treatment going forward and your relationship with them. Sorry, I'm going to exit out of this real. Oh, whoops. The green screen was not helpful. Let's go back into this. Sorry for the delay. So I'm going to jump into another case. This is a case of a patient that I met in the emergency department. This is a man from Eritrea who presented for severe right foot pain. Started about 10 years ago. This is the history he gave in the ED. Had surgery in the past of what sounded like a skin graft. Is now presenting because he recently moved here, doesn't have a doctor. He also had some swelling, especially at the bottom of his foot, where at the site of a skin graft, and it occasionally leaves some fluid. On some further history, he says that he was in prison with a metal shackle in Egypt and had surgery in Israel. Had since fled to the US, but now has to wear an ankle monitor on his left ankle. Exams, labs, imaging didn't show anything acute requiring emergency level care. He was given some diclofenac gel and actually added him to my panel and scheduled to see him in clinic within a couple of weeks. So at our next visit, coming back to this, so again, started about 10 years ago, and upon further history, I found out that he was actually detained in Sudan, and then trafficked into slavery in Sinai, Egypt, after fleeing Eritrea. He had a metal shackle on his right ankle for years, suffered burns and beatings, was sent to an Israeli hospital for a skin graft, and there he attempted to seek asylum. And I don't know if many people know, many people in Israel, or Israeli policy towards asylum seekers is quite strict and conservative, and he was actually going to face further imprisonment as an undocumented person, or he had a choice to go back to Eritrea and face persecution. He chose the latter because of his trauma already while imprisoned. So he went back to Eritrea, and he actually fled to Brazil by plane and made an overland journey through South and Central America to the US, where he was detained by ICE in Texas. Fortunately, he had family in the Seattle area, and after being imprisoned in an ICE facility for about, I believe, 8 months, he was able to connect with his family, but ICE then placed a GPS monitor on his left ankle that he was wearing in clinic today. So his main concern, however, continues to be treatment of his right foot pain and itching. So the focus of that first visit and multiple visits since then has really been on the multimodal treatment of his chronic pain, the severe itching that sounded like neuropathic, And as we discuss his asylum case, find out that he is a lawyer in Texas. He has to wear this ankle monitor. Currently not allowed to work, hoping that will change. He did not want to discuss any mental health problems. He just wants to focus on his foot. And actually saw him in clinic yesterday, and that story remains true. So the interventions, in addition to the health screenings that we talked about, is I connected with his lawyer in Texas, documented his trauma history and everything he told me very succinctly, but very specifically of everything that he had suffered, in the hopes of removing this GPS monitor, which, as I heard yesterday, is still in the process, but they're hopeful that documentation and work with the lawyer will remove that from it. So the reason I bring out this example is just, again, to hammer in that need to be very specific and targeted with getting the history of torture that a lot of refugees and immigrants that you may come across face, especially when there is a legal challenge that they're undergoing and they have an asylum case. And then I want to touch on something that Anisha had earlier mentioned, is undocumented people and access to care. So undocumented people are actually ineligible for Medicaid and Medicare. As Anisha mentioned, there are like some state exemptions and some state programs. It's not standardized across the country. So the Washington Health Equity for Immigrants report in 2020, which I highly recommend people seek out. It's long, but it's very useful. And it shows that this is one of the biggest impacts to care for undocumented people. And multiple surveys, when you even ask them, what is your impediment to care? It's their access to care. So 46% of individuals, in the state of Washington are uninsured compared to 7% of the general population. And although they can get employer-based or private insurance, most don't have that luxury because they work hourly for commission or as contractors and are often not considered employees. And the main coverage is through the very offensively named Alien Emergency Medical Program, or AEM. It has some limited coverage for income-eligible persons and for specific medical conditions. And it does include, at least in the state of Washington, ER care, hospital admissions, so your emergency and acute care, cancer, dialysis, anti-rejection meds, and most recently COVID-19 assessment and testing. Okay, so to end on a little bit more of a positive note on this heavy topic, I want to make a plug for our caseworker cultural mediators at Harborview. This is developed through a community house calls program in 1994 by Dr. Kerry Jackson, who you saw in that video, works at an international medical clinic, and as well as many others. And they provide many services. A summary of them are here, navigation of the health system, coordinating care, but also a lot of things outside of medical care, such as job searches, schooling, many other invaluable tasks that we don't often think about in our clinic visits. And then they're incredible advocates for their patients, but also for their communities, and provide a lot of education to us as providers once we connect to them to help us with our cultural competencies or incompetencies, as well as providing health literacy for the patients. And they're also all qualified interpreters, and they'll serve, right now, they serve 6 language groups, Amharic, Cambodian, Somali, Swahili, Spanish, and Vietnamese. And this is a photo of them that I got from Ethnomed. And remember, you can also refer these patients both as an inpatient and outpatient. So talk to your CCNs on the wards, talk to your clinical staff, or call interpretive services. There's a form that you have to, it's a little bit antiquated, but you have to actually, you can email it or fax it whenever you make a referral, and it's based on availability. And it's something that we hope expands within Harborview. And that is all. Thanks for coming to my academic half day. Any questions?
I see one quick question on that, because I've seen this at Harborview a few times, is there are some folks who are members of a very small particular cultural group, especially in Seattle, who are unwilling for us to contact interpreters or mediators because they are terrified that that person, because the community is so small, is going to get their information back to the rest of the community. What have you done then? Because there's somebody I remember last year who was unfortunately now dead due to untreated HIV, who refused to let anyone talk to him in his native language, and we were speaking to him in French that he barely knew because of that, and it was quite an issue.
That's a really good question, Alex. I have seen that once before. Unfortunately, we were able to talk to the patient and their specific concerns, and they were willing to talk and kind of like being very directed about their care. It wasn't a topic of HIV, which I imagine is a lot more sensitive of an issue. I don't have any great wisdom on that other than, truly trying to elicit all of the specific fears, and maybe talk I guess it's challenging with HIPAA of do you talk to somebody from the culture and see if you can mediate something without disclosing any any of their personal information. But yeah, that's challenging. I don't know if other people here, Shri, I know you work at the IMC. I don't know if you have any wisdom on this, not to call you out.
Yeah, I think, we have our best practices for using interpreters in the healthcare setting, using trained interpreters. One thing I'd say is that we have to do the best that we can. And sometimes if patients are uncomfortable and they prefer a family member to interpret, and that's all that's available, then that's what we have to use. It's not ideal, but in some situations I've run into, they don't want anything else. So that's just the only thing I'll add.
Yeah, I agree. It's not ideal to not use trained interpreters, but if the patient's adamant and you do have a family or friend, that is the best option. But it sounds like in this case, Alex, that wasn't available.
It was not. No, I've seen maybe 3 or 4 people in this situation, unfortunately. Not the same group in either case, but it was really tough because they wouldn't let anybody, including any family or friends, interact. So yeah, there's no easy solution. I just wasn't sure if you'd know it before.
No, there are apps, but I imagine that they're less helpful in smaller language groups. Some patients have told me when they didn't want to use it, and I've used an app to translate and interpret for them as best I could on the inpatient side. But yeah, not ideal.
Thank you for such a thoughtful talk and for this really helpful discussion. I will make sure that this is uploaded to the OneDrive. We'll make sure the slides are available. I think everybody's got access in the chat to that helpful resource that you shared. And I hope that this can be a talk that gets repeated in the future because I think it's really important. Let's take a break for 2 minutes until 10:50, and then we can get started with Carly's talk on anemia. And I don't know if you can see the chat right now, Hasib, but there are just like thousands of thank yous. This was incredible, fantastic. So thank you.
Of course, thank you all for engaging. Appreciate it.